Just 1 minute, ma'am.
Yeah.
We are going
Yes.
live.
Yes.
Yes, ma'am. We are live now. I'll share the CV.
A very good afternoon to all respected seniors and friends and viewers of this webinar. It's a great and a proud privilege to welcome you all. This is Fox's International Academic Exchange Committee webinar in association with AMOX Yuva Webinar Series and AMOX Medical Legal Committee. Convener of this series is Dr. Pratibha Singh Madam. On behalf of her and my co-conveners, Dr. Monica Umbardan, Dr. Sujit Kondkar, Dr. Madan Kamble, Dr. Suyoga Panat, and Dr. Jaya Tulaskar, I extend a very warm welcome to you all. I will request convener of today's webinar, Dr. Pratibha Singh Madam, to kindly give her welcome address. Friends, as we all know, Madam is a very generous, kind, and supportive lady. She's a laparoscopic and surgeon and ART consultant at Bhagalpur and is chairperson of Fox's International Academic Exchange Committee. Welcome, ma'am.
Thank you. Thank you, Dr. Rashmi. Can you hear me? Hello?
Yes, ma'am.
Yeah. So, very good evening to all of you. And at the outset, I would like to welcome all of you. And it's my immense pleasure to welcome you all for this webinar of International Academic Exchange Committee. And I'm really indebted to our President Foxy, Dr. Jaideep Tang, for giving me this platform to organize such excellent international academic exchange program under IAC. And my regards to Secretary General Dr. Madhuri Patel ma'am and my VP in charge, Dr. Nilja Vatla ma'am, for their constant guidance. And today, I'm really indebted to AMOX for giving me this opportunity to arrange this webinar in collaboration with International Academic Exchange Committee, Foxy. And most respectfully, I would like to welcome all our esteemed faculties for their glorious presence. And I'm really very happy and would like to welcome our chief guest and the President AMOGS, Dr. Kiran Kurtukoti, sir. Thank you, sir, for giving us this opportunity. And then I would also like to welcome our guest of honor, our evergreen, Dr. Madhuri Patel, ma'am, Secretary General, Dr. Vipin Pandit, sir, for their valuable presence, and Dr. Rajen Singh Pardesi, sir, who is always there for us whenever we need him. So thank you, sir, and welcome to this forum today. Now, obstetric hemorrhage is one of the most common and dangerous complications of childbirth. And to talk on this, we have great speakers. And for that, I would like to welcome our international speaker, although we had Dr. Thomas before that, but because of his some health issues, he is unable to join. So most respectfully, I would like to welcome Dr. Rashida Hakim from Australia. And she will be talking on PPH bundle, which is a different way of conceptualizing PPH emergencies responses that integrate crucial clinical and system-based interventions for rapid, effective PPH emergency care. So looking forward for a very informative talk from Dr. Rashida. Welcome to this forum. Our next speaker is our own Dr. Murlidhar Pai, a great academician. And I'm sure his talk on surgical management on PPH will be very useful to improve our skills on PPH management. And the next talk is on PAS by Dr. Archana Baser, ma'am. So welcome, ma'am. And I know it will be a great academic feast today. So once again, a warm welcome to all of you. And thank you so much for your valuable time. And for this, we have very brilliant chairpersons also. So most humbly, I would like to welcome all Dr. Ashish from Nagpur, Dr. Suyoga Panat, Dr. Srinivas Gadappa, Dr. Alka Pandey ma'am, Dr. Shobha Gudi madam, Dr. Meenu Agrawal, and I'm sure we'll get great input from all of them. I also want to welcome our conveners, Dr. Rashmi Kahar, Dr. Monica, Dr. Sujit, Dr. Madan Kamble, and Dr. Jaya Kore. And Dr. Rashmi, thank you so much for for giving such a great help and organizing this webinar. And I know it will enrich our knowledge and will be a great academic feast for all of us. So enjoy the sessions. And once again, a warm welcome to all of you. And thank you so much. Over to Dr. Rashmi.
Yeah, good evening, respected seniors, dear friends and colleagues. It's my honor to introduce and invite and welcome our chief guest today, respected Dr. Kiran Kurtukoti, sir. We are eagerly waiting for your words of wisdom, sir.
Thank you. Thank you. Well, first of all, thank you, Foxy, for taking Ambox on your platform. So thank you, Jaideep Tank. Thank you, Pratibha ji. Jaideep Tank, wherever you are, a very belated
Happy birthday, actually.
belated birthday wishes to you, Jaideep, wherever you are and if at all you are listening. So I also acknowledge the presence of Dr. Pardeshi, past president of Ambox, Madhuri, and of course, Dr. Bipin Pandit. Well, today's conveners, Dr. Pratibha Singh and Dr. Rashmi Kahar. What can I say about today's program? PPH always evokes a lot of interest amongst everyone because it is one of the commonest dreaded maternity, morbidity and mortality issues. So today we have, I also acknowledge the presence of Dr. Rashida. So thank you, Dr. Rashida, our overseas speaker, for being with us. And of course, thank you to Dr. Murlidhar and Dr. Archana Basir also. So I look forward to this particular workshop and my very best wishes to all of you for the same. Thank you.
Thank you, sir.
Thank you, sir.
Hello.
It's my great honor to welcome Dr. Madhuri Patel, madam, to today's webinar. We would like to hear from you, madam.
Thank you, Rashmi. Thank you, so nice of you for your kind and warm words. So, respected our President, Dr. Kiran, Amok's President, and our President, Dr. Jaideep Tran. I think he is very busy today because he's celebrating his birthday along with the work. So, I wish him happy birthday on this platform so everybody can hear. And Kiran, my great friend, and we had a great time in Pune. And Dr. Pardesi, we were together in Mumbai, so he's also my very great friend, we all are together. And of course, today's, then we have Dr. Amaya, Dr. Bharti, then Dr. Rashmi, and Dr. Madhuri, Dr. Rohan, Dr. Nilesh, Dr. Sujit, and Dr. Rashida we have, and we have so many people, from all the Amox and the Foxy, and of course our Pratibha. She's doing a great work being on international committee, chairperson sanction committee. She's doing great work, and in international committee she has taken us to Paris, and now she's going to take us to the Busan. So you all are welcome for this conference. Then of course we have very great speaker today, Thomas Burke, and we had done a PPH workshop with him in a UP. Because what is happening, whoever this gives us the donors, they concentrate more on the states which are with a high maternal mortality rate. So, they work over there. So he had worked with us in UP and we had a fantastic result in UP with him. Of course, with other, were also involved. And then Dr. Murlidhar Pai, he is a great orator. And third is our Archana Basir. So we are going to listen from them. And the chairperson are also fantastic, Dr. Our chairperson, I will not take name, but I would like to see my mobile. So chairpersons are Dr. Ashish, Dr. Suyoga, then Dr. Srinivas, Dr. Alka, Dr. Shobha, Dr. Meenu. And I cannot forget to say Monica, Suyoga, Sujit, and Madan and Jaya. They are all great coordinator. Let me say that our mission, Amok's mission and the Foxy mission, we are working on the same mission. And our mission primary is reduction in maternal mortality rate. And PPH contributes about 38% of the maternal mortality rate in India. So there are many states who have already achieved. And Maharashtra, I always give the example. Kerala is forefront, but Dr. Padesh and Dr. Kiran, I had for the government meeting, in long back. And that time, Dr. Deshpande had come out with how the Maharashtra maternal mortality they could reduce. That he had analyzed and said that the 99% now in Maharashtra institutional delivery, Then they improve the manpower in form of obstetrician, and thirdly, they could improve the infrastructure. So the maternal mortality of Maharashtra has reduced to 33 per 100,000 live birth. So by 2030, our goal of sustainable development goal 2030 is less than 70 per 100,000 live birth, and we are 97. Our nation is 97. So this is very achieve, means very recommended, very good, rate of our MMR at present, and we are definitely going to achieve the sustainable development goal of 2030 less than 70 by 20, per 100,000 labor. Only my request to the all the states who have already achieved this target of less than 70 per 100,000, they should go now into the single digit of maternal mortality rate by 2030. So it is going to be very helpful to all our mothers and our nation, because if the mother is not there, the family is disturbed, the society is disturbed, and the nation is disturbed. So another cause, what I realize is the anemia. Of course, Fogsi is working for PPH workshop, all the PPH. We have leadership development, initiative. Then Dr. Jaideep has got a big grant of Bill Melinda, grant of almost 16-17 crores, where they are going to concentrate to work in UP, Bihar, and 4 states, that is your UP, Bihar, and the 2 more states, that is Madhya Pradesh and Odisha. So, and Manyata, everybody knows our flagship program where we teach 16 points, WHO standards. Majority of them are intrapartum. And anemia, we all have to fight with anemia, because 60 to 70% is prevalence rate. It has remained same, throughout since so many years. So the public awareness, community programs are going to help us. That also will reduce the maternal mortality rate, which is responsible of indirectly for the PPA. So let us hear from our speakers and chairperson, our expert, which will enlighten us on the topics and which will help us in our day-to-day practice to reduce the maternal mortality and morbidity due to postpartum hemorrhage. And I congratulate Dr. Kiran, Dr. Jaideep, Dr. Pratibha, Dr. Rashmi, and of course other Suyoga is also there. So all the AMOX chairperson who are there, I congratulate them, and Dr. Pardeshi for the most apt webinar, and wish them best luck. Thank you once again for giving me this opportunity.
Thank you so much, madam. You are always encouraging us. Thank you very much, ma'am. So can we request our next guest of honor, Dr. Rajendra Singh Pardeshi sir, to give us blessings.
Good evening, everybody. Respected Chief Guest, Dr. Kiran Kurtakoti sir, our ever smiling and ever active President of AMOX. Then guest of honors, Dr. Madhuri Patel ma'am, our motherly figure in Fogsi, and see her knowledge about anemia, PPH, and all that. We need leaders like Dr. Madhuri Patel in future also. Then Dr. Bipin Pandit, Dr. Pratibha Singh, and our AMOX pillars, Dr. Suyoga Panat, Dr. Rashmi Kaur, Dr. Monica Umbardand, Dr. Sujit Konkar, Dr. Madan Kamble, Dr. Jaya Tuskar. And first, I wish to congratulate especially to Dr. Pratibha Singh, Dr. Suyoga Panat, and Dr. Rashmi Kaur for organizing this webinar on PPH and placenta accreta, and which contributes around 25 to 30% cause of maternal mortality. And as Dr. Madhuri Patel told, I am proud of our Amoxians, ma'am, for contributing to reduce MMR up to 33. And now, which we have targeted to reduce this MMR single digit. And hope we will achieve this single digit MMR under the able leadership of Dr. Kiran Kurtakoti. Of course, we are all with you, Dr. Kiran. And with eminent faculties and chairpersons, the faculties like Rashida, Dr. Rashida Hakim, Dr. Murlidhar Pai, Dr. Archana, Dr. Srinivas, Dr. Alka Pandey, Dr. Meenu Agarwal, Dr. Shubha Guri. I think this will be a great event. I wish every success to Dr. Meenu Agarwal, who is contesting for VP. Every success to her in future endeavor, and also to Dr. Sujit Konkar and Rashmi Kaur for their chairperson's elections in Fogsi elections in the future. Wishing every success to this webinar. Thank you. Thank you so much for inviting me.
Thank you very much for your kind and encouraging words, sir. Thank you so much. So, Dr. Bipin Pandit sir is not able to join at present, and we would like to hear from him when he joins. So now we can proceed to our scientific session. I would like to hand over to Dr. Monica for scientific session. Dr. Jaya, you can take. Please
Dr.
unmute yourself,
Unmute.
Jaya.
Unmute yourself.
Good evening, everyone. Starting with the first scientific session, that is drugs used in management of PPH. We have our esteemed speaker, Dr. Rashida Hakim, madam from Australia, and respected chairpersons for this session are Dr. Ashish Zararia, sir, and Dr. Suyega Panath, ma'am. May I have the slides? So, with great pleasure, I would like to introduce Dr. Suyoga, madam. Madam is consultant obstetrician and gynecologist, past president of Amravati OBGYN Society, and she is currently chairperson of medical legal committee. So I welcome you, ma'am. And
Thank you.
our next chairperson, Dr. Ashish Zararia, sir. Sir is associate professor OBGY GMCH Nagpur. I also welcome you, sir, and would like to ask you to introduce Dr. Rashida, madam, our esteemed speaker.
Thank you, Jaya. It's an honor to be here on this platform. Thank you, Rashmi ma'am, for this opportunity. So let me have the pleasure to introduce Dr. Rashida. She's our own Mumbaiite. She's from KEM, and she is pursuing her career in obstetrics at Australia. And she is she has achieved her fancy OG. I am really not sure what how important it is for practice in overseas, but I think she could be able to tell us about that. And she will be talking about drugs and postpartum hemorrhage. And I, along with Thomas Burke, has really worked on this bundle approach since its inception. Our team was comprised of Dr. Poonam Shivkumar ma'am, Dr. Fidvi sir, Dr. Kshama Kedar ma'am, Anuja Bhalera ma'am, and many more. So 13 medical colleges were part of this PPH bundle approach when it started in India, and then we have taken it to UP and Bangladesh. So I was a part of that team, a small member in that team. So it's my real privilege to introduce the speaker and being a part of this forum. So over to Rashida ma'am. You can start your talk on.
Can I just add a few lines about Dr.
Sure,
Rashida,
ma'am.
if you permit me, sir?
Yes.
So Rashida is my batchmate, so I have seen the other side apart from academics also. She has a very artistic side to her too, sir. She does very good paintings as well as she's very much interested in Mehndi also. And she's very, very sincere and dedicated to anything that she touches.
Great. So over to you, Rashida ma'am.
Good evening, everyone. I think I need to share my screen so that I can share the presentation.
You
It
can
just says
share.
it says host disable participant screen sharing.
Okay, let me make you go. You are the co-host, ma'am. You can share now.
Okay, so Are you able to see my presentation?
Yes, ma'am. Yes.
Yes, you
Okay,
are,
I am
it's
going
visible,
to
ma'am.
try and occupy the whole screen. I'm still the old generation, so I find it very hard to sort these things out.
You can go on the lower side. The lower side.
Rashida, there's a button of slideshow on the right hand corner of your screen. Right hand corner.
Actually doesn't let me.
Ma'am, lower corner, right hand.
Right hand lower corner.
1 minute. I might just stop share and try it again, okay? Share screen. It's sharing, isn't it?
Yes, you need to
You can you have to start the ma'am. You have to start the PPT by going lower down. You have to click on the lower side somewhere here.
At the extreme bottom of the screen, there's a
Rectangular box is there. You can see, Rashida.
Okay, I might just expand this itself. Okay.
You have to go on the start slideshow option, ma'am.
Yeah. Oh my God, I can't believe I'm taking so long to do this.
Ma'am, you can try pressing Control F5.
See my screen now? Because for me, it's sharing it completely. Is it good?
We cannot see the screen.
It's coming actually. Yeah.
You
Yeah,
still
I
can't
see.
see the screen?
We can see. We
Yes,
can.
yes, it's visible.
But it's not
Because
full.
I've shared it now.
Ma'am, try
Yes,
pressing Control F5. Control F5. Together.
Yeah. Nothing's happening.
Okay, ma'am, can you see on the right hand side corner 120% is written?
Yeah.
On the side of it, there's a mark. Yeah, can you press it?
It's not doing anything, is it?
Okay. Yeah, on the left hand side of 120%, the minus sign is there. Plus sign and minus.
After that.
Yeah, that's good now. Thank you very much for your help. So thank you to Fogsi, AMOGS, and all my very, very seniors for giving me this opportunity. I got the notice just yesterday to present about PPH, so I didn't know exactly what y'all were looking for, but I thought that I might just share some evidence for the medical management of PPH that we do and why, so it kind of it's more clearer to especially our junior doctors or our doctors working in the more remote areas on the management and what they should do and why they do. So now it's not letting me move my...
Click on the slide. Click on the slide.
Okay, so oxytocin, the most commonly used drug that we all use all over the world for postpartum hemorrhage. The onset of action for oxytocin intravenous is 1 to 6 minutes, intramuscular is 3 to 5 minutes, but its half-life is only 4 minutes. My screen's just changed on its own. Is anyone else trying to control the screen? No.
No, ma'am, only you can share it.
Yeah, because it's just
You might
not
be
like...
pressing the mouse by mistake. your hand or the sleeve of your whatever you're wearing might be touching your mouse pad by mistake.
Bhavna, will you please operate the slides?
I cannot, ma'am. I do not have the slides.
Okay, Rashida, if you can share the slides, PPT on my WhatsApp.
Yeah, actually, it's something to do with my laptop now because it's just not letting me exit.
If you don't mind, I'm Murlidhar Pai here. Can I request that let me talk first if that is not sorted out? Because I have a lecture at 6 o'clock.
I think that's a great idea. I might just leave the meeting for a second.
Yeah, better.
Because I have a lecture at 6 o'clock with Dr.
Okay.
Sneha Boyar's webinar.
Okay.
That's also AMOGS. That starts at 6 o'clock.
Yes, sir, I think we can.
Sir, you can share. Sir, you can share. Dr.
Yeah, sorry for this. So let me just quickly share my slide and we'll go ahead with this talk.
Yeah.
So there is no need to no need of any introduction. So let me jump into the talk. Okay. So yeah. Fine. Right. So the surgical management comes into picture when all other managements or basically the medical management has failed. You see, but how do you decide that a medical management has failed? After vaginal delivery, if the bleeding continues despite well contracted and retracted uterus. So when you give medical management, the endpoint is a well contracted and retracted uterus. Despite that, if there is bleeding, then you should think she requires a surgical management. So what should you do? You look for extension of episiotomy or perineal tears or vaginal laceration, cervical tears, and all these definitely require a thorough exploration under proper light. Sometimes you may have to take her into OT under general anesthesia, and all of them require prompt suturing. But if the uterus is not responding to your active management of third stage labor, which consists of massaging the uterus or bimanual compression or any of the tamponade procedures like ballooning or the medical management, suspect there is either inversion of uterus or morbidly adherent placenta, or there could be a rupture of uterus which you never anticipated. Maybe it was a case for VBAC, or even if it was a normal delivery without previous cesarean section, maybe with a previous scar on the uterus due to myomectomy, you must suspect probably there is a rupture uterus. So let us tackle one by one. Now, inversion of uterus, if it happens right in front of you, then Johnson's management of inversion is good enough, which is discovered as it happens and without much shock in the patient. She is bleeding all right, but she is not in shock yet. So this can be managed immediately in the labor room itself. All that you need to do is immediate replacement by pushing it back. While pushing it back, the portion of the uterus that came last should be pushed first, and finally the fundus will go back on its own. Now the next question is, should we replace it? Suppose the placenta was still attached, by removing the placenta or without removing the placenta? Obviously, we should not remove the placenta because there can be severe bleeding. You replace it along with placenta and then go for controlled cord traction, because you know this uterus has a tendency for inversion. If the patient is in shock, on the other hand, you have to do simultaneous resuscitation followed by reduction of the inverted uterus, but now you may require deep general anesthesia. So this is what is we can do if it happens right in front of your eyes. Now, sometimes it has happened and you are not in a position to replace it in the labor room and not even in the OT under general anesthesia because it has inverted so much, let's say grade 4, then you need to have a surgical management. You may have to do a laparotomy. So here there are two methods. One is Huntington's method, wherein, as you can see, after laparotomy, you will see like a nice deep well in the uterine fundus. And you can see sometimes only 2 fimbria of the tubes because ovaries also probably would have gone inside that. Here, what you can do, you can use multiple Alice forceps or clamps and slowly try to pull up, starting again from the portion went last first, and slowly using Alice forceps or Babcock's forceps, you can pull out the tubes and other things. Somebody from below can push the fundus, but one has to be careful. Many a times this can yield us good results. If it fails, then we have to go for Haltein's method, wherein you may have to do an incision on the posterior rim of the cervix, that is here where the arrow is being shown, and then you can insert your finger inside and slowly correct the inversion. Rest of it is same. Then finally you can close the posterior insertion. Nowadays, people use Celastic vacuum cup. You can place the cup at the well of this inversion and slowly increase the vacuum and slowly keep pulling it up. It is easier said than done, and I have absolutely no experience in this. People have tried to reduce it instead of laparotomy by laparoscopy also. Again, the principles will be same. I personally have not done this laparoscopically, whereas I have done a couple of times by laparotomy. Very, very rarely you may require hysterotomy or rather hysterectomy as a last resort. But then this hysterectomy is also not very easy because the anatomy is distorted and you have to at least get the ovaries out. Otherwise, you will not be able to clamp the infundibulopelvic ligaments. The second problem is morbidly adherent placenta. Now, when you have a case, you have to quickly confirm by ultrasound, which is available nowadays in most of the labor rooms. Then once you confirm that, if it is a simple adherence, then all that you need to do is manual removal of placenta under deep general anesthesia. Patient is wheeled into the OT. And then, of course, if the cord is still there, it is good thing because you can use the cord as a guide into the uterus and you have to slice all the placenta if possible and get entire placenta en masse and one shot. Otherwise, if it is removed in piecemeal, then again there will be problems. Whereas if it is accreta, then it is better to go for hysterectomy followed by removal of, or rather hysterotomy, followed by removal of as much as possible. I am talking about post-vaginal delivery. If it happens or if it is come across during cesarean section, of course, uterus is already open. After vaginal delivery, you have to remove the, you have to open the uterus. That's why I use the word hysterotomy. But rarely people remove the portion of the myometrium also, because I'm using the word rarely because even though it is advocated as PPP method, this will leave a big rent in the uterus and that can be a good case for a rupture uterus in the next pregnancy. Most of the time, the PPP procedures should follow a tubectomy. If it is increta and percreta, of course, according to modern guidelines, you have no business to allow for vaginal delivery. We have to do a elective cesarean hysterectomy. However, we still come across cases where people have not realized that it is a case of increta or percreta before delivery. They would have allowed vaginal delivery and later they realize that it is a case of increta or percreta, in which case there is no other option than doing an emergency hysterectomy. And whenever you do hysterectomy, we have to try to do a complete hysterectomy rather than a partial hysterectomy as much as possible. The last thing is rupture of the uterus. I am talking about after vaginal delivery, there could be a rupture of the uterus. And this, of course, requires simultaneous resuscitation as well as peripartum hysterectomy. So it has to be done in a tertiary care center. Suppose there is no time to transfer the patient from a secondary level hospital. If you have expertise, if you have enough amount of blood and the instruments, because this hysterectomy is not going to be a simple hysterectomy. It is an enlarged uterus, supple uterus, and all the tissues are very, very soft and all the vessels are dilated. That is the reason it is better tackled in a tertiary care center. You can transfer the patient with all pneumatic chute or whatever available, and then it is taken up in a tertiary care center. As I said earlier, experienced obstetrician is very, very important here. And there should be a backup senior anesthetist, urologist, because there is a chance that you may injure the ureters, and vascular surgeon, because as I said, the vessels are highly dilated and there is a chance of rupturing them also. Blood bank with enough blood product should be there. ICU facilities with ventilators in case the patient goes into shock and post-hysterectomy, she may have to be kept for some times in ICU. Counseling is very, very important, especially while making decision for hysterectomy, and you have to explain that she may require ICU care as well. And once you remove the uterus, of course, there is no chance of her conceiving. All these things have to be counseled to her. Of course, it goes without saying you have to take consent for hysterectomy. So all these things go without telling. CBC, coagulation profile, and cultures have to be done. Massive transfusion protocol is alerted. A central line with 2 large bore IV lines. Catheterization is, if possible, urethral 3-way catheter is better. Some people also want to have ureteric catheterization if time permits and if the specialist is available in the hospital. Action items that will be needed for in the event of emergency hysterectomy should be there, obviously. What are the key principles or what are the deviations from a gynecological hysterectomy? Here in emergency with an unstable patient, clamping the uterine blood vessels take precedence over adhesive lysis, packing, and cleaning. You have to quickly clamp the bleeding area, and so that the bleeding is contained, as well as you may have to clamp the major vessels or major pedicles first, and you can cut. Leisurely, you can suture them. So pedicles can be rapidly clamped, cut and dropped to be sutured later. So the usual acronym goes clamp, cut and drop, that is CCD. Other things says when the patient is hemodynamically stable, obtaining adequate exposure and uterine traction will minimize the vascular and ureteral injuries. So we can do that. If bladder can't be easily pushed down, a sharp dissection is preferred or urologist's help is sought. Every attempt should be made to identify the ureter time to time to avoid the ligating. That's why some people believe in putting a ureteric catheter. If there is adherent placenta, it should be left in place as removal can increase the total blood loss. Anyway, the uterus is going to go out. There is no point in doing this unnecessary exercise of removing placenta. So the steps, of course, some people believe in putting a tourniquet. Rubber catheter can be put, temporarily shuts off the uterine vessels and prevents the massive bleeding from the accreted placenta. The general principle, there is no specific technique as such. Same steps as in gynecological hysterectomy should be simple enough to perform rapidly. Leave as minimal dead space and raw space as possible if there is a coagulopathy. Clamps applied close to the uterus because there is a fear of injuring the other ureters and things like that. Don't include excessive tissues, and ligaments and vessels held by 3 clamps, that is 2 lateral and 1 medial, and keep good stump, so like this, so that you can do a double ligation instead of simple. This is the hysterectomy we did for a placenta in Crete. Surgical management of atonic PPH. Now, the uterus is intact. There is no rupture. There is no inversion. There is no adherent placenta. you have given the best of the medical management, still there is atonic PPH. So here, the surgical management is, number one is stepwise devascularization. Number two is compression of the sutures, uterus by sutures. And number three is internal iliac ligation. And finally, of course, hysterectomy here also. Stepwise devascularization includes, as you can see here, first you can ligate the uterine artery, left uterine artery, and then you can go for bilateral uterine artery ligation. And of course, then you go down and lower uterine artery ligation to include cervicovaginal branches and vaginal artery. So this is the stepwise. So one side, both sides, and at the starting point of the uterine artery, which includes the cervical and vaginal arteries. Then, of course, if that is not contained, maybe there is a supply coming from the ovarian vessels. You all know that ovary is a direct branch of aorta, so there will be high pressure there. So you can now start clamping the ovarian vessels near the utero-ovarian anastomosis, not at the infundibulopelvic ligament. That would stop the supply to the ovaries also. That can be dangerous. But if the bleeding is so much, saving patient's life is more important than saving the ovaries. So you can then go for ligation of the ovarian vessels as well. And finally, of course, uterine artery ligation, you can do at the starting point. It is effective in 90% of the cases. There have been lots of compression sutures. There are a lot of controversies and other things. I don't want to get into details of them, but B-line suture has been the most popular one. This particular picture, what you're seeing, is done when it is post-cesarean section, so that you have an incision already on the uterus. It is like a brace sutures, vertical brace sutures. It will work like a tamponade to control the hemorrhage. Uterine incision is needed for this. Suppose you are doing a brace sutures after the normal vaginal delivery, where there is no uterine incision, then you can go for Heyman or Arul Kumaran modification of the B-linge. Here there is no uterine incision. You are simply putting two vertical sutures, and needle is passed from anterior wall to the posterior wall above the bladder refraction, obviously. If you want, you can put additional transfer sutures at these are the transfer sutures, which is at the isthmocervical junction. Cho suggested, multiple sutures through anterior to posterior wall, 2 to 3 centimeter lateral above and below, making a square. This is not very difficult, easy to perform instead of just two brace sutures. Then there is a sandwich technique where you use both the compression sutures from outside as well as a balloon from inside. So it is a compression suture plus balloon tamponade. What you can do is B-line suture is the best for that. In fact, that's the only one which can be used here, because that does not occlude the uterine cavity totally. Hence, it can be used in combination with the intrauterine balloon. What are the sequence? First, you insert a B-line suture technique as usual, but don't tie it. Insert a balloon and fill it with 100 ml of fluid. Close the uterine incision, taking care not to burst the balloon. Then finally, you can tie off the B-line sutures. Inflate the balloon further if you want to have a better compression. Check for anything later and further bleeding. Internal iliac ligation, of course, nowadays we have sort of lost the art of doing this. Some obstetricians still do this, but in places like wherever you have the facilities with the vascular surgeon, you take their help also. It is not a very difficult one, but it can be mastered as well by obstetricians. But if there is a help from the vascular surgeon, nothing like that. Finally, hysterectomy. I have already explained the principles of hysterectomy, so I'm not going to repeat. Clamp and drop technique, double ligatures, and do as far as possible total hysterectomy, and take care of descending cervical and vaginal arteries. That is very important. Otherwise, even after hysterectomy, if it is bleeding, then removing the stump or containing the cervical and vaginal arteries is going to be Herculean task. So I think I have completed the talk of the different possibilities in a surgical management. Thank you so much for your patient listening. And I'm sorry to, make a forcible entry because I had to leave this place. And I also saw there are some technical issues. So I made use of that. I'm sorry, Dr. Rashida, for barging inside.
It was very lucid and wonderful presentation, sir. Now I would like to request Dr. Alka Pandey ma'am for her views.
Dr. Murlidhar Pai, I really admire you and your academics, and your talk was very nice. And I think internal iliac ligation, one thing that internal iliac ligation should be taught to each and every postgraduate, because everyone does not have a vascular surgeon, and it is something which is not very difficult. In cases when we were postgraduates and residents and professors, then we used to do Verdheim's operation, and in that case, internal iliac ligation, internal iliac artery was traced, and we were very familiar with it, and it is really a life-saving procedure. In one of my patients who had placenta percreta, what happened? Accreta, I mean, we did hysterectomy for her, and after 5 or 6 days, she started bleeding, and we tried packing and high antibiotics, and also a few haze wire sutures in the vaginal wall, but it did not listen, and she started pouring on the 10th day. So I had no option except that internal iliac ligation or go for a embolization. So we thought कि internal iliac ligation हम लोग के हाथ की बात है. So we did that, and luckily the patient was saved. So your talk was really brilliant, and thank you very much for
Thank you so much,
enhancing
madam.
knowledge.
Thank you so much. I agree with you. But nowadays, doing hysterectomy and cesareans itself has become difficulty with the number of PGs and others. So I doubt whether everybody will have a chance to get trained for internal iliac ligation. But I agree with you.
Yes,
We should know that.
Thank you, madam.
Thank you so
much. Dr. Gadappa sir is here. Dr. Srinivas Gadappa sir
Yeah.
is here. We'd like to hear from you, sir.
Yeah, good evening, ma'am. Thank you for calling me as a chairperson. Sorry for the late entry, but I heard Dr. Muralidhar Pai sir. It was a wonderful and excellent lecture, as usual, sir gives it. And he has covered total surgical management PPH in a nutshell. And definitely about internally at what Alka Pandey madam said, I fully agree with her, because this is the time now that obstetricians should be well versed with the technique of internal ligation. And also I want to say that as we are learning surgical skills, the importance of the time is also important, because there are so many surgical techniques are developed. So we must use that PPH bundle, that golden hour should be used, because if we are doing all these techniques and late, then morbidity and mortality is often seen, or ICU admission is there. So even putting all these things in one thing is also important. I really admire Muralidhar Pai sir for a wonderful lecture, and he has covered everything in a short time. Thank you, sir. Thank you very much.
Thank you very much. Please excuse me. I will leave this webinar
Yes,
for the other.
Yes, sir.
Thank you, sir. Wonderful talk.
So we will move on to Dr. Rashida's
Rashida,
session.
yeah.
And I would like Dr. Jaya to kindly share the slides.
The previous picture history.
Your WhatsApp screen is seen.
Yeah.
Is it visible now?
No, this is WhatsApp screen.
This is WhatsApp screen.
Correct.
And your conversation with me is visible.
Now?
Ma'am, please stop sharing and then share again.
Okay, just a minute.
Now please close the window of WhatsApp and then please
I have.
Open your PPT.
Okay. Is it visible now? No?
Yet
Yes,
it
yes,
become visible.
just a minute.
Yes.
Is it now?
Started screen share.
Okay.
It's visible.
Yes.
Make it full screen and go.
Ma'am, please click on
It is full
enable
screen.
editing. Please click on enable editing.
Just a minute. Huh?
The yellow bar, there is
Yes, I
one
know, but
enable
I'm not able
editing.
to do it. Just yes.
You have to click on enable editing, ma'am.
Yes, just a minute.
Ma'am, you have to first click on enable editing on the top of it. The yellow line, there is one bar.
Click
Enable
to more
editing.
details after that.
Yes, I am not able to do it. Don't know why, because the full screen is not visible here also.
Ma'am, you have to first click on enable editing. Not this, ma'am.
Enable editing.
Yes, I
on
know.
the upper line.
I know. Just
yeah. Yes, now you can do this share screen.
Yes, we can see now.
Yeah, thank you.
Yeah.
We'll move on to the first slide.
It's not moving.
Click on the slide.
Yes, just.
Yeah.
Yes.
Yeah, that's the first one. That's right. So I'm going to do the drugs with everyone. So the first most important one, oxytocin, which we all use worldwide. I've used it in India as well. We know it's a neuropeptide. It's released from the posterior pituitary. It basically, the expression of the oxytocin receptor increases 300-fold during the pregnancy. And the direct molecular connection it has to the contractile machinery in the uterus itself. But if you overstimulate by using too much oxytocin, you can desensitize the uterus as well. So using it in the right dose and at the right time is really important. The next slide. So the importance between all these drugs are what are their onsets, what are their half-lives, so that we use them correctly. So oxytocin, when it's used intravenous, 1 to 6 minutes, whereas intramuscular, 3 to 5 minute time for onset, and half-life is only 4 minutes. The adverse effects are generally rare, but it can cause hypotension. So imagine in a woman who's already hypertensive because of a big PPH, it can still cause hypotension. So we have to fill her vascular system with 2 liters of fluid. Hypersensitivity is again a very rare reaction to oxytocin, but can happen. Oxytocin reduces the risk of PPH of more than a liter by 41%. So the relative risk is 0.59 and 95% confidence is in the confidence range. Is one PPH management. Next slide. Sintometrin, one of our other very favorite drugs in India. And I think I used it way more in India than I use it in Australia. Everyone here tends to use oxytocin as a bolus rather than sintometrin because of the vomiting that it can cause. But it's 5 international units of oxytocin along with 500 microgram of ergometrin. And because of this combination, it's an amazing drug. Onset is 2 to 3 minutes, and it has a very long half-life of 120 minutes. That's why sintometrin is a way better first-line drug rather than oxytocin itself. Adverse effect can cause hypertension. That's why we don't use it in women with PIH or preeclampsia. 2 to 3-fold increased vomiting risk compared to oxytocin. And sometimes it's better to give a woman metoclopramide or ondansetron even before you give the sintometrin. Sintometrin reduces the risk of PPH of more than a liter by 51%, so slightly even more than oxytocin. Relative risk is 0.49, and it is in the confidence interval. This was one of the Cochrane papers. And then there was another one that says sintometrin is 30% more effective than oxytocin in reducing PPHs, which were even less than 500 ml. So 500 ml relative risk is 0.70. So it works in kind of all situations and all scenarios, can be used as a primary prevention as well. Next slide. Now, the newer drug, which I didn't use when I was training in India 15 years ago, is carbetocin, which came in after a few years when I finished my training. It is a drug that has an onset of 1 to 6 minutes when given intravenous and half-life of 40 minutes. And what is this carbetocin? It's basically giving oxytocin in a synthetic form, but the molecule has been changed. So it has a much longer half-life of 40 minutes versus the 4 minutes of oxytocin. Adverse effects are rare. Again, it can cause issues with hypertension. So you have to be very careful with women who have preeclampsia or PIH. No more vomiting than oxytocin because it's similar to the oxytocin molecule. So that's not a problem with carbetocin. Carbetocin reduces the risk of PPH by more than a liter by 48%. And this was again a Cochrane review 2018. So the risk reduction is 0.52, and it is again within the 95 confidence interval. So it is very relevant. Next slide. Carbetocin is 28% more effective than oxytocin, but with similar side effects. This was again the same Cochrane review of 2018, and that's why it's important to sometimes use this drug versus the 50% reduced need, 4% reduced need for additional uterotonics for women having vaginal birth. Carbetocin was most effective of all the drugs to reduce actually the blood loss and need for more uterotonics even at cesarean section. So actually in a lot of our hospitals, carbetocin has replaced giving oxytocin or even symptometrin at the time of cesarean section. Next slide. So conclusion for primary prevention of PPH are that we have these 3 drugs: oxytocin, carbetocin, symptometrin. They are all effective if you compare them to a placebo, so they all work for PPH. But should oxytocin be our real first line, considering its half-life? So symptometrin actually seems to be more effective than oxytocin. So I think we do it the right way in most of our Indian hospitals where we use symptometrin as the first line. And carbetocin seems to be more effective than oxytocin, and it should probably replace the symptometrin or oxytocin given at the time of cesarean section. And there are no increased side effects. So the overview of the whole PPH is we've done the primary, now we go on to the secondary prevention. So when a woman is actually bleeding, we have other options when we've already finished using our primary prevention drugs, which are oxytocin and the symptometrin in most of the situation. Then the secondary prevention comes in place where we have drugs like ergometrin, carboprost, misoprostol, and the newer one that is tranexamic acid. Next slide. So ergometrin, it is a serotonergic receptor agonist, partial alpha-adrenergic receptor agonist, and also has weak dopaminergic receptor antagonist. So basically, it is contracting smooth muscles in the body. So it even contracts the smooth muscles in the blood vessel, causing issues with hypertension. And that's why it's a no-no with preeclampsia and blood pressure issues. Its onset intravenous is 1 to 3 minutes, and its half-life is long. So it can be anywhere from 30 to 120 minutes. Adverse effects, it causes vomiting. There is actually 3-fold increase compared with simple oxytocin. It causes sometimes hypertension, and there is hypersensitivity to the drug as well. So especially for hypertensive disorders, cardiac diseases where we don't want the woman to be hypertensive, it is contraindicated. But again, it's a relative contraindication. So for example, if you are in a really remote place, a woman has preeclampsia, but she's already bled more than a liter, coming up to 2 liters, is very hypotensive. In that situation, I would still use ergometrin because her blood pressure is already in the booth. So rather use ergometrin and save her life. Efficacy. Ergometrin reduces the risk of PPH of a liter by 37%. So relative risk 0.63, and it's still again within the 90 proven evidence-wise to be used. Next slide. Now, misoprostol, this is the one that came into a little bit of controversy recently. So we know it's a prostaglandin E1 analog. The most rapid absorption is actually oral or sublingual. Women don't like it having it under the tongue because it takes a very long time to dissolve, but actually works much better given sublingual or oral versus putting it rectal, whereas we all tend to put it rectal when we are doing the bimanual and nothing is working and we just put the misoprostol PR. But the better way, if the woman is awake, is to give it to her orally or even better sublingually. Adverse effects are vomiting, pyrexia, which are threefold more increased compared to oxytocin. Next slide. So efficacy, misoprostol reduces the risk of PPH of 1 liter by 29%. So in the Cochrane review, they said relative risk reduction of 0.71 was within the confidence interval. As a lone agent, it was ranked low in the cumulative rankogram because we can see how it's only 29% effective. Two meta-analyses suggested that misoprostol is actually less effective than oxytocin. It was the 2020 Cochrane review and 2022 network analysis, which was published in the AMJOG. So hence, we have to be very careful. It actually doesn't do much compared to our other drugs. Next slide. Then we have the carboprost, which is a drug we generally don't keep in our birthing suites or in the delivery room. This is more a drug used by the anesthetist or at the time of cesarean or in theater with a massive PPH that the anesthetist helps us to, administer it because it is prostaglandin E2 alpha. It's given intramuscularly, 250 microgram, half-life 8 minutes. You can give actually up to 8 doses or a total of 2 milligram. It can cause bronchospasm. That's why to have a friendly anesthetist at the time with you is always good. And if you don't and you're giving it in delivery suite, always be very cautious. Efficacy is not really proven. So carboprost does not reduce the risk of PPH more than a liter versus placebo. So it's a relative risk of 88, but the confidence interval is too broad, which was proved in the Cochrane review of 2018. So carboprost alone is inferior to oxytocin alone in a recent network meta-analysis as well in the AMJOG. Next slide. So tranexamic acid, inhibitor of plasminogen activation, it basically inhibits fibrinolysis. Fibrinolysis increases with trauma and after birth because there's that placental separation, which is also causing that trauma kind of a reaction. So it stabilizes clot formation. Its antifibrinolytic action persists up to 17 hours. It's a lysine analog. It binds onto the plasminogen. Plasminogen still turns into plasmin, but plasmin cannot bind and it breaks down the fibrin. That's how the mechanism of its work is. Next slide. So you give 1 gram, which is 10 mLs in a basically 100 milligram per ml solution. Onset, it works within 5 minutes and it has a long half-life of 120 minutes. Adverse effects are generally rare. You just have to be cautious. Does the woman have a history of thromboembolic events? But I don't remember ever finding a woman with a major thromboembolic issue other than sometimes when they were recurrent pregnancy loss and we knew they were having factor V laden or one of the important mutations. So basically, tranexamic acid is a very easily available and easy to use drug that we know works with a longer half-life. But this is one of those drugs that need to be given at the right time. The longer you waste time and not give it, the less effective it is. Next slide. So the woman trial, which was published in Lancet 2017 regarding PPH, had 20,060 patients that were treated for PPH in 193 hospitals across 21 countries. Primary outcome they were seeing was death due to bleeding, which is a very difficult outcome to actually chase. Initially, it was death, and then they had to change it for hysterectomy because we know that that primary outcome, you need a very, very large sample size. Tranexamic acid reduced the deaths due to bleeding by 19%, so 1.5 versus 1.9% in the non-tranexamic group, and the p-value was 0.04. 0.45. It did not reduce all reduction was particularly large if it was given within 3 hours. And we actually emphasize more now that it should be given within the hour. So at the first onset of PPH, you should just give the tranexamic acid. In fact, it's so widely used now that even during surgeries, if you think a patient is bleeding a bit more than what you would like, you rather give tranexamic acid intra-op than wait for after. Next slide. Then we had the TRAP-1 study in the NEJM, which was a post-vaginal birth can be used the tranexamic acid, and there were 4,079 participants. 3,891 had vaginal birth, 15 maternity units were involved. Tranexamic acid was added along with oxytocin or carbetocin, and it was powered to show a 30% reduction. So tranexamic acid did not reduce PPH versus placebo in that, but it was a non-significant reduction in this particular study. Those who had tranexamic acid had additional uterotonics, so 25% less often. So this created a little bit of controversy. Next slide. And then came the TRAP-2 in NEJM, which was during cesarean section. So 4,551 participants at cesarean section. They used tranexamic acid or placebo, 27 maternity hospital. Outcome was again checking how many women had a PPH of more than 1 liter or required blood transfusion. Among these women, 41% had oxytocin, 59 had carbetocin. So they were like balanced study. Tranexamic acid decreased the composite outcome by 16% in the study. P-value was 0.03 and secondary outcomes were not statistically significant though. Thromboembolism was seen in 0.4% in the tranexamic acid group versus 0.1% in the placebo. So we always have to be careful about that history of previous family history of thromboembolism, or the patient could be at risk of thromboembolism. Next slide. MFM network in US had an abstract in 2022, which had 10,995 randomized patients during labor, tranexamic acid versus placebo at cesarean section. Primary outcome was composite maternal death or blood. Primary outcome, 3.6% tranexamic acid arm and 4.3% in the placebo arm actually had the PPH. Treatment for bleeding needed less often in tranexamic acid group. Pre versus post-op decrease in hemoglobin was less in the tranexamic acid group. So no difference in thromboembolic complications. So this study then again brought back the evidence that we should continue to use tranexamic acid for whatever good it is. Next slide. So basically, we still continue to use the tranexamic acid. And in the secondary group, we can use all of the drugs that we've spoken about. It's just misoprostol that we do have to be a bit careful because we might be using it too much, but we're using it for the doctor's sake, not for the patient's sake, because it doesn't really work that much for the patients. But that's it. And thank you, everyone, for giving me the opportunity to present.
Thank you, madam, for the very elaborative and very fruitful talk. Actually, that message which you have given, that the timing of administration of the drugs is very important. That is, I think that is the take-home message, because the drugs given well in time can save PPH and save a mother's life. So thank you, madam. And thank you, Rashmi, and thank you, Pratibha Singh, madam, for including my committee and me in this webinar and giving me an opportunity to share this session.
I would like to ask one question. Madam has said misoprostol is not that effective, but Government of India has recommended misoprostol, and WHO also has recommended misoprostol 600 milligram in places where you do not have the facility for keeping oxytocin in a cold chain. In the rural areas, it is recommended. So whether it is a right thing or not, I would like Dr. Rashida to answer.
I totally agree with you. The thing is that it's very different for us when we do things in a first world country where we have fridges everywhere, even the smallest hospital, there's a very good cold chain maintained drugs. I was thinking, I actually went on Google to check that we have carbetocin and other drugs available in India at the time. But I totally agree with you. Where we have lack of drugs, whatever we think makes even a little bit of difference should be used. So using misoprostol way more than in a first world country for an Indian, especially rural setting, where a setting where we don't have enough drugs, it's still important. Totally agree.
In fact, it is also included in the government's program that
Thank
one
you,
tablet
madam.
of misoprostol, 600 micrograms, should be used immediately after the delivery so as to reduce the PPH. Yeah.
Yes, I think that's what Rashida is endorsing also.
Yes.
And in critical conditions, whatever is going to help us, we have to use it.
But FIVO also recommends misoprostol.
Rashida,
I think since the latest evidence, like sometimes there's always a backlog for WHO, FIGO to change their things. But if you go according to evidence, we know that it doesn't work as well as the others. But yes, you should not stop using it when you don't have any other thing. But you have to keep in mind that it might not be doing as much for the woman as much as you're thinking it is doing.
Okay, thank you, ma'am.
Thank you so much, Rashida. And we are especially thankful to you. And we all wish you a very blessed Ramadan.
Thank you very much.
Thank you for being here.
Thank you.
Jaya, you have to unmute yourself.
Yes. So moving on to our third session. Can I have the slide, Bhavna?
Bhavna, are you there?
Yes, ma'am.
Please put the slides.
Yes, ma'am.
Our third session is about placenta accreta spectrum. We have respected speaker Dr. Archana Basir madam, and as chairpersons, we have Dr. Shobha Gudi madam and Dr. Vinu Agrawal ma'am. So it's with great honor I would like to introduce madam, Dr. Shobha Gudi madam. Madam is Professor HOD at Philomenas Hospital, Bangalore. And I welcome you, ma'am.
Yeah.
We have another esteemed chairperson. Next slide, please. We have respected Dr. Meenu Agrawal, madam. Madam is currently president, Pune Obstetrics and Gynecological Society. She has been awarded with many awards like India's Greatest Leaders, Icons of Health, Inspiring Gynecologist of West India. I welcome you, ma'am, and I would like to request you to please introduce our esteemed speaker for today's session.
Thank you, Dr. Jaya. Very, very sincere and very, you have been really keeping in touch with everyone. And it's a great pleasure for me to introduce Dr. Archana Basir. She has been the Vice President Fogsi in 2020. I mean, I followed her as the imaging science chairperson. She was the most dynamic imaging science chairperson. It was difficult for me to fit into her shoes. And she's also been a Guinness World Record holder for removing the largest sized fibroid. And she also has been the organizing secretary and the managing committee member of ISAR. A great friend, very humble, and always smiling, and a very good hearted and a gracious friend. So thank you very much. And we would like to hear from you about the placenta accreta and the issues associated with that. So Dr. Archana Basir here, please.
Good evening, everyone. And thank you. I committee for inviting me to speak on my favorite topic, placenta accreta syndrome. Rashmi has been very, closely following us up. That yes, the link has been sent and everything. Thank you, Jaya. And it is really good to be amongst the friends, Dr. Meenu Agarwal and Dr. Shobha Guri, multi-talented people. And let's see, I do justice to the topic given to me. And Dr. Pratibha Singh, who is the chair, and she's been closely listening to all of us. So please allow me to share my screen. So I think you heard a great talks by Dr. Pai and Dr. Rashida. It's all regarding the postpartum hemorrhage. I have a little bit changed the heading to tips and tricks to diagnose placenta accreta syndrome by ultrasound, because being in the imaging science and doing the ultrasound, I think why I have changed and why I'm doing that is because we need to really predict. We are living in an era where we need to predict. Can we really predict if this patient is going to have PPH, this patient has placenta accreta syndrome? Yes, it is very much predictable if we have good ultrasound facilities and we are tuned to scan ourselves, or maybe our colleagues are being tuned to scan the placenta, which is something which is just reported as anterior posterior, but I'm going to cover that in my talk. So what I'm going to be covering is what is the problem magnitude, introduction of placenta accreta syndrome and risk factors and predictors. How do you diagnose placenta accreta syndrome by 2D ultrasound, color Doppler, MRI, and placenta accreta index. If you look at the problem of placenta accreta syndrome, that is short form is PAS, the incidence of PAS has risen from 0.8 per thousand to over 3 per thousand over the last decade, and the incidence continues to rise. Series from the past decade suggests that the prevalence has increased to 1 in 500 to 1 in 900 pregnancies. And if you look at the RCOG data, placenta accreta with 1, 2, 3, and 4, 5 cesarean section, 3%, 11%, 40%, 60%, and 67% respectively. What is the PAS, placenta accreta syndrome? Accreta means total placenta accreta. It involves all the lobes. Increta means partial placenta accreta involves only, accreta, total placenta accreta, partial placenta accreta, and focal placenta accreta. And you have placenta increta and placenta percreta. Placenta, what are the, just a minute, give me a second. Yeah. So these are the forms of the abnormal attachment of placenta, and it is encountered in approximately, accreta is encountered in 75% of cases, whereas increta develops in 15 to 20% and percreta in 5 to 10% of the cases of PAS. However, placenta accreta is also the general term frequently applied to encompass all three of these conditions. A practical consideration in that the distinction is often not made until delivery. So you know that it's a PAS, but you don't know whether it is accreta, percreta, or increta. So what are the risk factors for PAS? If patient is having placenta previa, we know that she is at a risk of PAS, so 5 to 10% risk in a patient with placenta previa. If a woman is having previous cesarean section, then she is at a high risk of PAS. Multiparity, advanced maternal age, if she had a uterine artery embolization, endometrial thermal ablation, vigorous multiple curettage, and if there are uterine pathology like adenomyosis, bicornuate uterus, submucous fibroid, Escherman syndrome, and previous history of uterine surgeries, hysterectomy, myomectomy, especially the women who conceived on ART treatment, they had adenomyosis or some other abnormality of the uterus, they are at increased risk of having placenta accreta syndrome. There are recently some biochemical risk factors are being identified which can predict PAS. One is the elevated first trimester PAPE. We all are doing our double markers in the first trimester along with the NT. So look at the PAPE level, down regulation of specific microRNA, elevated second trimester MSAFP and free beta HCG, decreased tumor necrotizing factor related apoptosis, including ligand receptor level, myometrial fibers in basal plate, and maternal cell-free beta HCG. Can we prevent placenta accreta? Well, placenta accreta is an iatrogenic 20th century disorder. If you use correct surgical technique while performing cesarean section, you certainly are reducing the incidence of placenta accreta syndrome. If the first place, primary prevention of first C-section will help reducing PAS, treatment of postpartum endometritis, like the women keep coming after C-section or after delivery with discharge or irregular bleeding and some kind of fever, I think they needs to be taken seriously and treat their endometritis and avoidance of vigorous curettage. These are the factors which can be prevented. Now, how do you diagnose placenta accreta syndrome? You can diagnose it by ultrasonography. Transabdominal, one is the history, which the pointers I have told you in the history. By ultrasonography, transabdominal ultrasound, it is reliable. It's a primary tool for antenatal diagnosis of placenta accreta syndrome. Transvaginal scan, detailed assessment of invasiveness is more sensitive by transvaginal ultrasound than transabdominal scan, and it should be done at 20th week of gestation. Why transvaginal ultrasound? Transvaginal ultrasound improves accuracy of placental localization when the placenta is especially posterior, if the transabdominal scan is unclear. For example, due to maternal obesity or presence of large uterine fibroids, it is difficult to assess the placental location. Transvaginal scan will reclassify 26 to 60% of placentas diagnosed as low-lying at the routine fetal anomaly scan. So it is very, very important to perform a transvaginal sonography, especially in the cases of posterior placenta, to look for the low-lying placenta and to put the color Doppler to see the placenta accreta syndrome. Ultrasound, should we be doing MRI if we have placenta previa diagnosed or there's a PAS you are suspecting? We should be aware that the diagnostic value of MRI and ultrasound imaging in detecting placenta is similar when performed by the experts. So MRI may be used to complement ultrasound imaging to assess the depth of invasion and lateral extension of myometrial invasion, especially posterior placental and or women with ultrasound diagnosis suggestive of signs of parametrial invasion. So what is the algorithm for placenta previa? Anomalies can do at 18 to 22 weeks, which most of us are doing with proper placental localization and transvaginal scan and cervical length assessment. If the placenta is low-lying, it is less than 2 centimeters from cervical os or placenta completely covering the os, consider early scan if cervix is short. Repeat ultrasound, especially along with the transvaginal scan at 32 weeks, low-lying placenta covering the os, repeat scan at 36 weeks, plus transvaginal scan, classify as previa or accreta, plan elective delivery, consider admission. Because rather than having the patient in emergency and in a place where there are no facilities available, it is better to scan and direct the patient to a proper place where she can be taken care of with her placenta accreta syndrome problem. Now, I've been talking about cervical length assessment along with the localization of the placenta. Why is that so? Cervical length measurement, when you're doing with a transvaginal scan in the placenta previa cases in the previous slide I have shown, it may help facilitate management decision in asymptomatic women with placenta previa. You have diagnosed placenta previa, patient has no bleeding, she has no symptoms, but when you are scanning and you find that the cervix is short on transvaginal scan, before 34 weeks of gestation in this case, it increases the risk of preterm delivery and massive hemorrhage at C-section. So it's a very important slide and very important point to take home, that do a cervical length assessment. If short, you can predict that there is going to be a massive hemorrhage. Now, some tips and tricks of imaging. When should you be examining? Mid-trimester fetal anatomy scan at around 16 weeks. Patient preparation, it has to be empty bladder. Route of scanning, transabdominal examination. If you are suspicious, then do transvaginal examination. Optimize machine setting and oral setting for cervical assessment and color Doppler. optimal planes, sagittal planes, other modalities. If a vasa previa is suspected, employ a spectral wave Doppler to confirm presence of arterial fetal vessel, low inferior placental age, high presenting fetal part. So that's again a sonographic clue for placenta previa. Sonographic clues to persistence is placenta extends over and beyond the internal hours, persistent at 32 weeks, then you know that it is a placenta previa. So just as simply you can diagnose placenta previa by a 2D grayscale sonography. When there is a loss of clear zone, loss of irregularities of the hypoechoic plane in the myometrium underneath the placental bed, abnormal placental lacunae, bladder wall interruption, and myometrial thinning. We will watch this in the scans. This is a retroplacental hypoechoic zone. If you are scanning, you will understand, or even this is very clear in the picture. This is the placenta. It's like a nice pancake placenta with no lacunae. This is your skin fat, and this is the myometrium, and there is a retroplacental hypoechoic zone, and there are the blood vessels, and they are running parallel to the placenta. There are no transgressing vessels. So if you are ordering a scan from your radiologist colleagues or anywhere, just ask them to put the color also along the placenta, so you know that you are going to be dealing with the problem, or it's just a placenta which is not adherent. Now in the first trimester also, you can predict placenta accreta. Nowadays we are shifting our scans and our anomalies and everything to first trimester so that we are better prepared. So presence of low-lying gestational sac in scar area is considered as high risk for placenta accreta. And with high resolution ultrasound availability and keeping in mind history of previous uterine surgeries, you can pick up the plausibility of placenta accreta even in the first trimester. This is our patient who keeps coming to us. She was for chorion-villus sampling for thalassemia. And look at this. This is her scan where you can find the transgressing vessel. We deferred the chorion-villus sampling in her case because you can see here is the cervix and the placenta is fully covering the os. And when I put my color, there was the transgressing vessels here. And ultrasonography finding in second and third trimester, loss of retroplacental sonolucent zone has high sensitivity. Thinning of retroplacental myometrium is highly specific feature of PAS. Multiple placental lacunae. These irregularities shaped hypoechoic vascular space may give the placenta a Swiss cheese appearance. They contain turbulent flow and thinning of retroplacental myometrium with the smallest myometrial thickness measuring less than 1 millimeter in sagittal plane. Look at this. This is quite like a Swiss cheese appearance, and there's a loss of sonolucent zone in the very thin myometrium here. This was a complete placenta previa in one of our patients where we had to do the obstetric hysterectomy because it was a percreta. The placental lacunae, most reliable sign of PAS is placental lacunae, which is very easily can be identified by the ultrasound, and it can be detected at as early as 12 weeks. On color Doppler, blood flow rate is more than 15 centimeter per second. It appears as moth-eaten appearance, irregular and linear, do not have echogenic border that standard venous sinuses have. Now, there is even a grading of placental lacunae, which is called Finberg and Williams grading scale. Grade 0, no lacunae. Grade 1, 1 to 3 small lacunae. Grade 2, 4 to 6 large lacunae. And grade 3, many large irregular lacunae. Look at there. There's a large placental lacunae on ultrasound. This is the placenta. This is the large lacunae on the ultrasound. There are some more anterior placenta previa with the sonographic, like look in the sagittal plane, there are lots of lacunae. So lacunae, you can easily see on the scan and you know if there are lacunae are present. This is the placenta previa, put the color and you might be able to see that there is a accreta syndrome. What do you see on Doppler? Dilated vessels and bridging vessels. So transvaginal ultrasound, multiple tortuous hypoechoic structures within the placenta. If you do the transabdominal scan, 2D Doppler on ultrasound, confirm the hypoechoic pattern, and 3D Doppler ultrasound for diagnosis of bladder invasion in placenta percreta seen as positive vascularization. Why I have put this slide? That are not in every case. If you don't have 3D available, you're not good in doing 3D ultrasound. So 3D is to be kept for where you know that there is a like invasion is suspected, you put the 3D, but if you have, you put it in every case of placenta previa. But even by a good 2D scan and putting the Doppler, you can predict and you that placenta accreta syndrome. And I'm not going into detail of MRI finding. You see the uterine bulging, lumpy contour, and dark intraplacental bands, focal gap in myometrial. So this is a typical picture on MRI of the placenta accreta syndrome. This is again the placenta accreta syndrome with, you can see here, there's a bladder invasion. Now this is image showing central placenta previa where you have Swiss cheese appearance and there is a loss of hypoechoic area and there is a very thin myometrium. And this is in the same case, there is subvascular, subplacental hypervascularity, that is the dilated vessels which can be seen, and this is the vessel covering the internal os that can be seen. This is again hypervascularity at utrovesical interface, demonstrating bladder invasion as well. You can see here all going into the bladder as well. Now the value of each parameter is added together to generate the placenta accreta index score. So like, what are the parameters they have considered? More than 2 C-section delivery, number of lacunae, sagittal smallest myometrial thickness, and they have scored it. If score is 0 to 5, there is a low probability of pass. Score is 6 to 7, there is moderate probability, and the score is 8 to 12, means there is a high probability of pass. So where do we miss placenta accreta syndrome? The biggest question is this: we are not suspecting it. So the lack of suspicion is the biggest problem. Reduced acceptability of the transvaginal sonography. I mean, in certain area, in certain places, do a transabdominal scan, but transvaginal scan is not a routine, which as a imaging science committee chair plus doing the courses for Fogsi, we were trying to emphasize that transvaginal scan can be done like what we to predict placenta accreta syndrome and to diagnose the placenta previa. You don't have to force the probe, just keep it a little away from the cervix, so you're not eliciting any bleeding, but you get the resolution and really detail of the placental position. So failure to look at the placenta, often placenta is not localized in third trimester scan and position copied from the previous report, thus leading to a vicious cycle of misdiagnosis. This is a very important point, that people just copy it. They look at the BPD, AC, FL, and Likert volume, but the placental position is invariably copied. Still considering MRI as the first line leading to delay in diagnosis, not applying color Doppler while doing scan. This is again very important point. I want to emphasize to all the obstetricians here that for the every case of placenta previa, please ask for color Doppler while doing the scan to look for the invasion. Not looking at bladder at every transvaginal scan. Keep the bladder maybe partially filled, so that on transvaginal scan you can look at the bladder, and bladder invasion can be picked up by a simple transvaginal scan. Not doing cervical length assessment by transvaginal scan, and not counseling patient appropriately. These are the very important points. These are very much doable, very much can be learned, and we can really reduce the morbidity and mortality associated with placenta accreta syndrome if we copy this in or practice this in our regular care. So I'm just going to now end with a couple of placenta previa case scenarios. Just one case I'll take. This is our patient, 34 years, gravida 3, previous 1 C-section, 8 years back, 1 curettage, husband not accompanying, she was dumb and deaf, referred to us with placenta previa at 36 weeks and possibility of accreta, diagnosed on ultrasound. It was her first this thing. On scan we found central placenta previa, breech presentation, and MRI was done to confirm placental invasion. It also confirmed previa with invasion. It is like biggest challenge in this case was to communicate and do the counseling with the patient. We were lucky, she had very caring and intelligent brother who understood the problem. She and consent of cesarean hysterectomy if needed, and morbidity, mortality, how to get it signed. But again, we were lucky, patient was graduate and she could sign, though she could not hear and read. So all consents were taken, and like how you manage placenta previa, blood units cross-matched, multidisciplinary team, NS30 and C-section was performed. And outcome of good communication and preparation was live male baby 2.8 kg. Placenta was central as it was adherent. We waited after angle suturing, complete placenta delivered. There was a moderate PPH controlled by uterotonics, and uterine incision was quickly closed and uterus was well contracted. So we were very lucky in this case that we came out safe, and the patient came out very safe along with the baby. Post-operative care was we monitored her closely for PPH, antibiotics were given, and very touchy thing, patient asked us in OT very simple question. She asked for a paper and a pen, and she wrote on a paper that MC yes or no, and that was really touching. So it was very important that a good communication, good preparation leads to a good outcome. So in conclusion, hemorrhage, we have heard about the hemorrhage surgical management with the medicine, and what I'm talking is the prediction and prevention of postpartum hemorrhage. It still remains the most common cause of maternal mortality, and population studies have shown that placenta accreta spectrum remains undiagnosed before delivery in 1/2 to 2/3 of cases, which is really, really alarming, especially in era of technology available to us. The only way to improve outcome is to improve prediction. If you predict, then you can really prepare, and you can really implement the correct measures to act upon. There is enough data to support that ultrasound is adequate in prevention, prediction and diagnosis, which is available even in remote areas. And there is no excuse anymore to miss a case of morbidly adherent placenta, nor we will make any excuses that surprises are acceptable only on birthdays and not on opening the abdomen. So we all should really take a pledge that yes, we will make sure that patients who are coming to us and have been regularly following us up, we predicted and diagnosed the placenta accreta syndrome before the patient is taken on operation table for delivery. And so take home message is prevent first placenta accreta syndrome by judiciously doing the cesarean section technically right and indication wise right. Predict the placenta accreta syndrome, prepare yourself, prepare team, and prepare the patient and relatives, perform in synchronized way, prognosticate it, and if nothing else, just the prayers, because they'll work. Thank you so much.
It was much elaborative, practical talk, ma'am, with beautiful USG pictures. Now I would like to request Dr. Shobha Gudi, madam, for her remarks.
Yeah, you can stop sharing the. Yeah, that's wonderful, Archana. It is so lovely to connect with you. It has been a long time, and my friend Meenu also. So let me thank the Yuva force in MOX, and thank you Rashmi, Suyoga, and Jaya, and I can see my friend Pratibha also there. So very nice to connect with you, Pratibha, on this platform. Very, I think Archana, you are such an expert in this topic. It's very difficult to kind of scale you on anything. It's always very excellent. And you know what inspired me maximum when I watched you work in imaging committee, and then Meenu work subsequent to you, was the kind of support you gave Meenu, and the way Meenu excelled in her chair. I was very surprised when Meenu did not apply for the committee award, and I told her that you have done such wonderful training sessions, and you should have applied. And the way you supported her and did not kind of, make a big deal out of it also, I was really impressed, Archana. These are qualities that very few leaders will have. And as a vice president also, you did such excellent work. About the talks today, what can I say? I think most of the work is coming from your own ultrasound machine, and that is why you are able to kind of relate to every case that you have done. You have given very clear messages. I had one question to ask. I think the audience, maybe there are some questions. Meenu, you can look it up. They have not posted any questions. If there are any questions, team, please post them here because we should not miss out. I'm sure there must be at least some. on this subject. So Archana, my question to you was very, very quickly that because today you are picking up Akrita at a very early stage. So if this is out of my own interest, in early pregnancy, if we find in previous scarred uterus, we find that the placentation is on the scar and the pregnancy is okay, and we counsel the family about this dangerous condition. Are there any guidelines to offer termination? Is what is, because this is going forward. It is such a life-threatening condition. So of course, if there are no live issues, we do not. But suppose the family is kind of okay, then what is the guideline for that? Is there any information on?
I think it's a very, very important question which you have put, Shobha, and it is very difficult to answer as well, because number one, this either ways it is very difficult. Like doing termination even with the placenta accreta syndrome in the first trimester is equally challenging. It is equally challenging. I think the proper counseling and considering the patient's wish, you have to put across that yes, it is a dangerous condition, that I mean women may lose her life as well when it is, and it has been picked up. It will depend on the extent of placenta accreta, like it is a percreta or it is increta or just only the placenta accreta. And I think you have to take it forward from there. There are no set guidelines that you should offer termination to a woman who has placenta accreta syndrome diagnosed at 12 weeks or 13 weeks of pregnancy. Only thing what we have to tell that we will have to have a very increased surveillance on you, and at any point of the time you may require termination of pregnancy. It may be 24 weeks, 28 weeks, depending on your situation, and just keep them at a high alert or just the red flag in the file. But there are no protocols. And I had once this ICOG a conference where this kind of a case was put across, that what do you do? Women wants termination. How do you do the termination when there is a placenta accreta syndrome? So that was a very nice discussion over there. Like you have to give methotrexate and first decrease the the blood supply and then do the termination. Even then you have to take the consent for the hysterectomy as well. So it is either ways. It is very, very difficult question
But
to answer.
why I put this forward is that it is a very progressive condition.
Yeah.
And as the placenta grows, the neoangiogenesis grows with that. And the risk of hemorrhage increases several fold, with every week of gestation. That is why I asked whether authorities have made up their mind that if they find it early, because then the number of blood transfusions will come down. Maybe we can save the organ, and it's possible. So that is the reason I asked out of interest, because it's going to be more and more in our practice every day. So I thought I'll just put this thought across to you.
And it is
so thank you very much again for a wonderful, and thanks for the opportunity to among for
very
giving me this.
important. I think it is. I think one of the committees in Fogsi, they can come up with the guidelines and they can take it up. Maybe the imaging
Some
science.
GCPR for pass has to be made separately, I feel. No,
maybe
something like that.
Yeah.
We should do it from ICOG, Archana. Let me ask. Okay. Then
So-
we can be together. Yeah.
Thank you so much. It was a very, very nice, very elaborate and very nice ultrasound pictures that Dr.
Very
Archana
good.
showed. And first of all, I would like to congratulate Dr. Rashmi Kahar and Pratibha Singh Madam that you both, Foxy and Amox, getting together and organizing.
Very nice.
Of course, the Dr. Jaideep Tank and Dr. Kiran Kutkoti, and they all came together, very nicely convened by Dr. Jaya here, the entire program. To your question, Dr. Shobha Gudi Madam, I had a patient who was Jehovah's Witness. So they didn't take any blood. So she came to me with placenta accreta. She was already 34 weeks at that time. And she was sent from, wherever she went to. And then she came to Ruby Hall to me to go ahead for the pregnancy. She was a African lady, Jehovah's Witness. Now they don't accept any blood or blood products. whatever, she gave a signature on the paper saying that even if I die on table, I will not take any blood products. So those was a difficult case to manage, but then, and then that maternal mortality and then things following that also, they are not easy to manage. However, we did take all high risk consent and everything, and she already had 4 children. This was her 5th child. So we delivered the baby, and we electively did a hysterectomy for her post-delivery. But yes, I mean, if she had come earlier, like you said, there was a possibility that we could have at least told her that maybe she could go in for a termination. So that was a
That
very
is true. Yeah. So we stand a little kind of uncertain about that, and many people will be facing this dilemma every day. So I just wanted to bring it up for discussion. Thank you very much, Jaya and Pratibha and Rashmi. Thank you so much for inviting me.
Full talk, Archana madam. It was wonderful. Yeah.
Thank you, Pratibha.
It was an amazing talk.
Very good. Yeah, really.
Amazing talk. It was a great learning experience.
Thank you so much.
Especially the slide where we miss that was, and take home messages also.
Thank you so much, Rashmi. Thank you, Pratibha. Thank you, Emox, and thank you, IAEC. Very nice to be connecting with all of you.
Thank you.
So nice.
It's nice to say, no, IAEC. It sounds so kind of
International, no?
International ho jata hai ekdam.
Committee. Because nowadays we are in the WhatsApp and a small
पर
SMS.
ये करेक्ट, प्रतिभा हमेशा इंटरनेशनल ही रहती है. वो भी है, पेरिस भी है और कोरिया भी है, सब कुछ है. So it's very good to interact with Pratibha, really. One feels very connected. Thank you, Pratibha, for involving all of us.
Thank you, madam.
Thank you so much, ma'am. I would like
Thank
to
you,
offer
all
a
of you.
formal vote of
Thank you
thanks
so much.
to my esteemed chairpersons, respected Dr. Shobha Gudi, madam, Dr. Minu Agrawal, madam, Dr. Alka Pandey, madam, Dr. Gadappa, sir, Dr. Suyoga Panat, and Dr. Ashish Jararia, and speakers, Dr. Archana Basir, madam, Dr. Pai, sir, and Dr. Rashida. And I'm also very much thankful to Fogsi leadership and Amox leadership, and my co-conveners, Dr. Suyoga Panat, Dr. Monika Umbardan, Dr. Sujit Kondkar, Dr. Madan Kamble, and my most helping coordinator, Dr. Jaya Kilaskar. And last but not the least, I'm very much thankful to the gorgeous, helping, and very cooperative and supportive Dr. Pratibha Singh, madam, for giving this opportunity. Thank you very much, ma'am.
Okay. Thanks. Thank you, Dr. Rashmi.
And special thanks to Core Connect, Corona Remedies, Bhavna Verma, and Abhishek Shah for their timeless efforts. Thank you very much, Abhishek. Thank you, Bhavna.
Okay.
Dr. Shobha, for your generous comments about the committee work, which I